And now we have a moderated discussion with these great speakers. Thank you both for your great talks. So I'd like to open the floor to questions.
I think it's a great question. The short answer is that we've taken the technology and spun up a startup and are partnering at a large scale, which I think is going to be essential. And yeah.
Thank you both for your talks. They're extremely interesting. This question is also for Dr. Petersen. I'm curious if you can talk more about how, in regards to matching behaviors to patient states, over here, by the way.
Thank you.
How do you ensure that you're matching the correct patient state to the behavior? For example, when you're going back to that patient with chest pain who the doctor had a gut feeling that he should do a CT head, which is extremely abnormal for a patient with chest pain. How do you ensure that you're not matching that behavior to something in regards to the chest pain patient state so that your model doesn't end up recommending CT heads on every patient that comes into the ER with chest pain?
I think this is where the causal piece of it has to come in. So there's a few, I guess, bases of this, that the doctor is making that recommendation based on something. It may be a gut feeling, but there's actually usually quite a lot in a patient's history and EHR. I think starting to untangle what are the patient histories and who are the patients, where that CT head actually makes a big difference, is where the causal piece of this comes in. So moving beyond kind of the prediction of this is an unusual thing to happen to like what are the settings and contexts in which this might actually causally change a patient's outcome, however defined, the time to right diagnosis or the clinical outcome. And I think that's, it's an example of a pattern that I think we see again and again, that fundamentally so few of the questions that we want to tackle in healthcare can be tackled without explicit links to causality. That fundamentally most of them are not prediction problems. So I think just as a general statement to like all of the amazing work going on in this room, that starting to bring in those explicit causal ties, and you did a beautiful talk on that as well, is going to be crucial, I think, to taking the AI to the next level. And not just saying, well, this is rare, or in this one setting, this patient did great, and so we should always recommend it.
Yeah, I can also comment a little bit on that because we do a lot of that kind of research too. I think actually the hard thing is to get the gold standard of this outcome, right? So even you have this algorithm, what are you training towards to? Because if you are just predicting mortality, you do have the mortality adjudicated. When you are, so that refers to the counterfactual. So you are actually required to see the difference between these patients and the same set of patients experiencing, like have two different types of provider or two different types of clinical actions. So one part of our work is actually to pairing observational data with clinical trials, because some of those questions were tested in clinical trials, but clinical trials typically are not suited for machine learning because the population is so homogeneous. So if eventually you want some large data sets, even like Optum Labs, I actually published many papers using that, you need hundreds of thousands of patients because some of the clinical actions might be rare and sometimes it's hard to match the patients. So you basically match, I think the EHR sometimes have more clinical information than claims. So you basically have a high dimensional propensity score matching, And then you basically have to first validate the average treatment effects before you go on to do the machine learning. So if that's the same approach you guys do, or?
I mean, I guess with the extension that I think once you start looking at longitudinal treatment paths, you can't do propensity score matching.
Yeah,
Like, it just doesn't work.
Exactly. So that's actually how you choose the causal. So what I didn't talk about is, because I'm not a data scientist, how you chose the causal machine learning methods depends on your clinical question. Because the method similar to self-driving cars, the reinforcement learning, right? So this kind of approach is more used in, say, ICU. There's a series of actions, and then you can get the effect quite recent to this action. And there are also other clinical problems, like do you do a prescription medication or do a device? There are two separate care pathways. So it depends on, so your choice of the model actually highly depend on whether you are doing this like just two different pathways or a series of actions. And there are, of course, the time-dependent propensity score or different weighting, you can use that to incorporate the information. But sometimes it's difficult in that the missing is not at random, right? So some people have certain state, they get the testing that the other arm or the other type of patients do not have similar information. So that brings some controversy in the matching. But we teach courses on the whole thing.
Yeah. And I do think that's a place where the idea of leveraging quote unquote conditional natural experiments at the provider level rather than the action level is an underused approach. The idea has existed for a long time, but an underused approach in some of the like more modern causal ML applications.
Thank you both so much.
Hi, could I jump in with a question here? Over on the other corner. So thank you both for the talks. My name is Chase. So I had a question kind of about the clinical behavioral policies. So as you're able to model more behavioral factors, I assume like you want to optimize the best outcome for the patient and learn those policies, but you also might be able to model other factors like clinician burnout, healthcare utilization, a lot of these other things. So I'm wondering, like, what are your thoughts on addressing conflicting objectives and like deciding what to include and what not to include when you learn the policies?
Yeah, that is a great question. I think maybe first part of the answer is that's why we kind of separated this into like foundational model of clinical behavioral model that's just sort of the model of everything but not fine-tuned to anything yet. And that's why it exists there in a separate box. I think then the potential is that you fine-tune the model or really the three-step process to very different objectives, users, outcomes. I think healthcare service delivery is a hugely important one. It's, depending on where you come from, it may or may not seem less glamorous, but hugely important in terms of driving patient impact, particularly under resource constraints and in our current setting. So I think the idea is that this is a core, and then it absolutely gets, where you, at the optimization step, you optimize for a specific objective, and it could be at the level of specific patient, it could be the level of a healthcare system as well, right? So like what are ways of delivering care across a healthcare system to optimize for X? Yeah, and then fine tune for that.
Yeah, so at current Center for the Science of Healthcare Delivery, so our department is specifically doing this kind of work, or we are the driver of Mayo's learning health system. So our approach to that question or the priority is often meet with clinical leadership first, and you have to talk with administrators, nursing, physicians, because if you only talk with a physician, they might have a different priority than the nursing. So you just like set the priority at the beginning, and you can somehow combine them if you want to weigh them in some way.
Hi, my name is Yang. I'm from Seattle Children's Hospital, and thank you both for the great talk. And this question is For Dr. Petersen, so when I'm looking at your framework laid out there, it's very beautiful. So you have patient state, you have physician actions, and going on, and the past actions and state become a context. And I think it probably will work very well in the ICU settings, because when patient mostly like lose their mobility, they cannot do anything. But what if a doctor takes action and the patient is not there, just passively receiving it? It often happens like, I'm not a doctor, so I receive a suggestion from doctor, and then I go home, I promise him I will do it, but then I don't do it. So the patient action is something I see missing in there for some settings, not all the settings. If for ICU, of course, you can do that. Patient is laying in bed all day, and but even that, some of the responses can be measured in the state of a patient. Like a lab is basically a reflection of whether the patient is going better or not. And the other thing is like the physician action. Like in hypothetical world, you can say we have the best action there, but in reality, doctors make mistakes too, and it's not necessarily mistakes. There's hierarchy of actions in his mind, and he chooses one, and then he chooses another one, and he chooses another one. And if it's another doctor, and maybe they might have the order reversed, sometimes that order might also make sense. I think that can be resolved by the learning process, but I'm still want to you learn something, right? You learn from the data. And how can you kind of see when you do machine learning, you clean the data, make sure that the data coming in has good quality. How do you resolve those type of problems? Thank you.
So there are like 5 questions in that, and I would love to love to continue. I'm going to try to do them from memory. Patient factors not included currently. So totally agree. I mean, to some extent, you can say, as you said, right, that when you have, for example, lab metrics that are picking up patient behaviors, that is part of the context that you're learning from when you do the actions. But I also agree that is an imperfect picture. I would say that is imperfect information that plagues not just an LCBM, that is more like our health system, right? Like chronic outpatient care, we are missing most of patients' lives, including some of the most important determinants. So actually very, not the talk for today, but very bullish about the opportunity for integrating like remote patient monitoring technologies and like direct-to-patient queries. I think one of the things that this tees up is the ability to identify in a proactive manner what are the specific pieces of missing information that would be the biggest drivers of better action plans and better outcomes. And then, I mean, this is getting another step ahead, but really what you can do is you could embed targeted data collection to start filling those in. So I think that's one very exciting direction. Oh, there was another one I really wanted to answer. Now I can't remember it. Just also that another piece of this is the patient perspective in terms of what treatments are going to work for them, what the procedures are, what their goals are. When we talk to different objectives, is it cost or efficiency or mortality? What about it's like, I want to live to go to my granddaughter's wedding. Or people have very different goals, and so I think that's another place where AI is opening up new opportunities to bring in the patient perspective. And I would say that's another place where I think the symbiosis of ambient listening technologies, which may be able to pick some of that up in conversations, as well as sort of language-based patient interface may be like very, very helpful in helping us to bring those perspectives into this kind of framework.
Yeah, I can add one comment for the first question. Well, typically, what you mentioned is flaws of using EHR data, right? So typically, we need to link EHR with claims because, like, the medication in EHR, you can only see the order. You don't know whether patient filled the medications. And if, say, physician recommend a test, they may receive at a different institution because they are cheaper than mail, right? So there are many other possibilities. So one thing is just link different data sources, EHR claims and device registries, because there are a lot of registries for rare disease device and procedures that will offer more information both for matching and for outcome, for longitudinal outcome tracking.
This is just comment. I think, this framework, in my mind, works really, really well in ICU settings where, the patient is very much managed within the clinical settings. You don't have to go out of that settings. Yeah, I think that's going to be very exciting. And when you think about expanding this to other places, to think about that, I think that's going to be
Thank you.
A low-hanging fruit, I think.
Thank you.
Hello. Yeah, excellent talks. Dr. Yao, I really like your presentation. So much information with lot less words on each slide on average. And I like the comment that you said that a lot of challenges that AI presents us, AI can also be used to tackle that. That's awesome. And also Dr. Petersen's awesome presentation. And I have a comment and a question. The one thing is where you say what action should come next. That's kind of, coincidentally, we were talking about the same thing in one of the roundtable discussions. I think it should be 3 levels, like what clinical knowledge says should happen. Second thing is what practical knowledge says what should happen. And the third level should be what must happen. So the reason I say that is, the good news is I got membership to HBO Max last night. And the first thing I saw was The Pit, the very first episode where this doctor is trying to treat somebody who everybody's saying, oh, we should do this, we should do this. And he say, no, you should just inject this big injection into his chest and then take the fluid out or something. He did something. So that must have happened. That's the third level. Because it's a TV series, it has to work, right? But in the real life, if he failed, all those guidelines and practical knowledge, he would have been sued or something, right? So those kind of things, like how do you capture then in LCBM? Those kind of things that are always changing. Medical knowledge is always changing. Government guidelines are always changing. How do you plan to capture that in the implementation part of all these great ideas? This is what I'm really curious about, but excellent, this is what should happen.
Great questions. Some brief answers. One is guidelines are always changing. Guidelines are in language. Guidelines are useful, and we should use them. But again, that they really only tap some of the answer. Like what do clinical guidelines say should happen? Often that's for a single intervention, like a choice of drug for a single condition at a single time. It's not for a complex patient with a lot going on. So there's not always a simple answer as to what should happen. That I see the sort of causally tuned large clinical behavioral model as an adjunct, not replacement for, but an adjunct to, but I think a very, very important one to things like clinical guidelines. I think that both are well suited to being updated as the knowledge base evolves, but it's the lived knowledge base as well as the written knowledge base. And finally, in answer to your question, which reminded me, I wanted to also say that in answer to the previous question, that I simplified the output just because got through a lot in 20 minutes. I hope I hit 20 minutes. But ultimately, it's not clear that you want a single answer. This action should come next. That's not really the right question either. And so I think one of the things we're working with is really depending on the complexity of the patient and the context, it may be that, look, here are 5 reasonable things to consider. Actually, there's a lot of uncertainty here. Here are 5 that may actually be more useful information to help guide a clinician, then here's the one thing. So understanding how to represent uncertainty about good next steps in a way that actually helps clinicians, I think is a big piece of this that I just sort of cruised past at a rapid rate.
Yeah, so because I'm very in the American College of Cardiology, we really put in a lot of thoughts on those guidelines. And I read them from the first page to the next page, and they're constantly updated expert opinions. So there are existing tools already feeding, like in taking those guidelines and trying to highlight those in the EHR. And one of my friends, he's an NLP or LLM expert, he's also has tools that can directly keep digesting, say, the CDC guideline on COVID, because during COVID, the guideline keep changing. So they feed those evolving guidelines from the website and coming up with individualized recommendations. So there are certain tools in development, but still the thing is in how accurate they are probably vary across patients, across diseases.
And
Thank you.
COVID guidelines are a really good example.
Thank you very much. Thank you.
Thank you. Very great talks. I have a couple of questions. I'll start by Dr. Yao. In one of your figures, it is shown like as the population grows, the RCT, I'll say ATE score, it's almost matching the one when you don't randomize the clinical trials. I wanted to know why. So my questions are mostly methodological. And then a follow-up question on that is, using ATE has some assumption about some homogeneous responses, which I think might be not the case in real life, because if we give a treatment to n different patients, we should have some expectation that the treatment, like the response, would depend on like the condition of like each patient X. So I was just wondering why, or whether you considered some other more informative metric like the CATE to be able to have more informed decision about like how the treatment works. And then I'll move to Dr. Petersen. It is about, still a methodological question. I've seen a lot of causal inference in your talks. I was wondering if you have an idea of where in between like the different steps causal discovery could come in, because a lot of like the co-founders and everything that you mentioned, if we have a proper, well-designed causal discovery process to discover, quote unquote, the true underlying process or mechanism, then we might avoid the like unobserved co-founders. We might also avoid some potential backdoors in like every causal graph that we build. And then that could also speed up the inference phase. And finally, you mentioned uncertainty, which is also something that I'm really interested in. My question would be, how do you think this could be leveraged? Because if we are thinking about model uncertainty, there are approaches that do that, and that refers to the most likely epistemic uncertainty of the model, which relies again on the model's knowledge. So is it uncertainty from a human perspective? If yes, how could that be measured to make sure that there is a good collaboration between the human and AI, like human-centered AI, like whole like cost and everything? So yeah, those were my questions.
So for the first question, the larger sample size in non-randomized studies doesn't guarantee a better causal inference. Often the larger sample size just often get you a more precisely wrong bias. I mean, just from less precisely biased to more precisely biased. It's just shrink your confidence interval. So, and the causal forest methods we use was actually to calculate the individual level treatment effect. I just didn't go into the details of that because there are a few things you can do, basically, before you develop the causal forest model, you first say do a propensity score match on a high dimensional thing. And then what we did is to at least first see the average treatment effect in trial eligible population, do they match the prior trial, or even because even you get the average treatment effect wrong, and then it's very hard to get to the individualized treatment effect. But essentially, the model calculates a treatment effect, basically means a difference in the outcomes between the two arms for each individual patient, tailoring their comorbidity like hypertension, heart failure, and whatever other conditions. And then we rank them by the most risk reduction to the least risk reduction of an intervention versus the other intervention, if that makes sense.
Yes, a couple of comments. Like,
Do you mind if we first go to the...
Nope. So causal discovery, I think briefly, the kind of causal graphs and approaches we're using are, the underlying causal models are really non-parametric structural equation models with no exclusion restrictions. So all of the structure is coming from time. So right now, it's less about let's use knowledge or discovery to rule out confounders, and more like let's actually tackle that whole massive temporal context at each of these steps. So we're not getting into trying to learn those causal relationships, we're just leveraging time in a massive way. Do I think there are interesting interfaces with these sorts of approaches in causal discovery? Absolutely, but that's probably a longer discussion, but happy to have it with you. Uncertainty, also these are great big topics. Uncertainty, super important question. To take a couple levels, one is there is actually underlying uncertainty in the best way to practice medicine. Like there's actually, given a certain context, there may well be several things that are very reasonable and good to do. And so at its core, what you want is output that encapsulates that and quantifies it accurately. So is essentially assigning reasonable probability to each of the actions that are actually reasonable to do in the given context rather than just a single one. So doing that in a way that's like well calibrated is like one important piece of this. Another piece of uncertainty is really comes into like the statistical machinery behind this. So in the sense that when we're looking at like what constitutes good quality care, what is like difference, I shudder whenever I say that, but there, quality care that leads to your desirable outcomes, are these meaningful differences or are they noise? That you have to do that within a rigorous statistical inference paradigm, and I think that's really where machine learning needs all of this work that's been done in the statistical theory domain also over the past decades to make sure that we get that inference right, because otherwise we react to things that are noise. So short answers to really excellent questions.
Okay, just a couple of follow-up. To Dr. Yao, I take the example of, for instance, where we have like two groups, like a drug being given to patients that are, I don't know, older than a given age, and the same drug being given to another category that are above that threshold, that age threshold. We assume, for instance, that for the first group it is, I don't know, +10, and for the second group is like -10. So the 80 between like that difference would just be 0. So following up what you said, still like basing on the ATE, don't you think that it still carries some, if I can say, bias? Like it's not really representing how every person is reacting to that drug.
So I guess because I'm not a data scientist, but my understanding of those causal machine learning methods is the causal machine learning methods learn from the data, so they will pick up a few combinations, say age, so they will pick up the most influential, say top 20, or they actually intake, say, hundreds of clinical variables of this patient, and not every variable drive the heterogeneous treatment effect equally. So it's just like a few combination or different type of combination, and they split the data, say the age or EGFR or ejection fraction, and as the algorithm learn from the data, so it might not split as I would split the data. So they figure out the split of the data, they figure out the combination, so they can combine the different clinical characteristics, higher order nonlinear term, combine them together to figure out a way to calculate. Yes, it probably in the small cluster level, it might be but it probably one of the best methods to calculate the HTE, but I'm not really because my question is always how to validate those things. When you calculate the treatment effect, how are you going to validate it in a different setting where you do not have counterfactual outcome? Even for the different type of provider, this is often a problem for us in terms of triage, right? So different providers see different types of patients. How do we figure out which type of provider? So it's still like more like that, but it's like better than like a totally human determination, because human typically make this decision based on 10 variables. This machine learning see like hundreds of variables trying to figure out which group they belong in.
So to finish, it's just a kind of philosophical question. What you both talked about like the future of AI and then how it can be applied to health to have better treatment, better like AI-based solutions. I was just wondering from a fundamental perspective, it's not something that I've heard a lot, but I've started hearing some people talking about open-ended discovery. And I'm wondering if you have an idea how that could be used in the specific context of like health care.
You mean open source algorithm, or what?
No, open-ended discovery. Like the fact that current AI models, we always teach them somehow how they should learn and things like that. But it is a new way, a new idea of not having some limitations and allowing those models to discover new theories that they think that are important for them to solve, things like that. So it's like we are not constraining those models, that we are not optimizing anything necessarily, but about the fact that leaving them explore. So roughly is about, for instance, themselves generating a problem that they think might be useful.
Just very briefly, because I know there's some other folks, but I do think that one of obviously the very interesting aspects of generative models is they make new suggestions we haven't thought about. So there is a hypothesis generating aspect of this work and the work of many in this room that I do think is incredibly important, but has to be obviously then linked to hypothesis testing. And then I would say there's like, as you laid out beautifully, the levels of hypothesis testing, for the first pass in terms of observational data, and then obviously taking it to the next level.
Thank you. I'm aware of time. I'll keep it very short. I'm Augustine. I'm a clinician by training. I've got a question for Dr. Petersen. One more practical, one more ethical. I'm wondering, so patient care now is very much subspecialized. Yeah. There's always multidisciplinary input. What test is done probably depends on who's on co-radiologist. How do you isolate that effect in your provider part in your model? And the medical question is, it sounds like what you can do now is to score each doctor's action and say how good it is. How do you think that would be perceived? And would it end up like doctors will be more likely to do something that aligns with the masses, because it sounds like that would score better in your model?
Oh, so such good questions, and let's see, I'll take them maybe in reverse. So first of all, we're doing this, they're totally de-identified, so not, you. And also really looking at like groups of physicians, it's easy to explain it in terms of the provider who's best for you. There's probably a group of providers de-identified whose practice patterns are causally linked to good outcomes for you. So it's more at that level. However, there is an extension of this that I think is extremely interesting. And my co-author, Dr. Kolstad, has led looking at different versions of you. So how does your own practice pattern differ when you are exhausted or overwhelmed or you've had a huge patient load? And actually the ability to use this underlying technology to instead perform like the best version of yourself. Like, so to call you out when you're like, actually this is not what you usually do. Are you sure you want to do this? And so I think you can, I think absolutely these have to be front and center. I think what this can't turn into is like, you're a good doctor, you're a bad doctor. And so it's how to get that nuance across in a 20-minute talk is hard, but I think it's very, very important. But I think what that has the potential to do is put humans back at the center of this and clinical knowledge back at the center of this, and then help say, okay, how do we get access to all this deep clinical knowledge that's everywhere? Your first one was methodological. Specialties. So that is I think one of the things I sort of breezed over here is like the attribution piece of this. So especially if you have a team, the team is responsible for different aspects of care, and together those aspects may combine to drive outcomes. Not an easy problem. I think one piece of this is you link specialties to types of actions, and then you have really, this gets into the whole agentic conversation, right? But you have specialist versions of this taking different roles and like taking responsibility for different portions of the action plan or the behavioral policy.
Hi, I'll be pretty brief because it's sort of related to the previous question. So when you are comparing across like how different providers, how their actions or the clinical steps that they take lead to different outcomes, and comparing them and trying to see what could be like a good route to suggest, is there any grouping happening in terms of the provider's resource? Meaning that it's great to ask the question, what would a Mayo Clinic physician do in this oncology case? But if that Mayo Clinic physician would order a total body PET CT, of which there are not that many in the country, and Mayo Clinic has multiple, 120 patient scans a day, or they order some 3D MRI, and how does that help the rural physician who has no access to that but probably would benefit from this kind of model the most? So both from like a design standpoint, but also from a testing standpoint, how that would be deployed basically.
Yes, such an important question, and to take it to the even one more step, because a lot of the applied work I do is in rural Kenya and Uganda, the resources are very, very different. And so I think that this is like a very general roadmap I gave. I think one of the attractions of having this very general roadmap is the ability to say the ability to fine tune your optimization problem. So that was a question earlier as well. So when you say, I'm looking for practice that leads to causally good outcomes that can be within a specific context, including care context, it can be within specific resources, it can be with access to certain parts of the action space. Given that, what does good care look like? And so I think that flexibility of the optimization at the fine-tuning stage is part of what gives this its potential reach. But great question.
And you might realize that too, that Mayo Clinic actually has a lot of rural practice across Wisconsin and Minnesota. So a lot of our work in using AI is actually to selecting which patients really need a test. Because sometimes they need to drive 50 miles, 100 miles in the winter to come in Rochester to receive a test. And so the AI helps like the patient selection in that. And also that's related to the triage question, who should receive the care at primary care? Because in the rural side, they typically do not have the specialists. Nowadays, they can use a lot of those virtual technologies, but still a lot of tests can only be done at academic medical centers. So the triage question, the patient selections are actually seeing a lot of AI potentials these days.
Totally agree.
One final question, and then we have to round up.
Great. Oh, hello. Thank you both for the wonderful talks. My name is Sheng Pu. I'm an assistant professor of computer science at Emory University. And my research actually studies AI for clinical decision making, focused on reinforcement learning techniques and EHR data. So my question is mainly towards Dr. Petersen. So in the examples you showed, the clinical pathways, you have these lab tests ordered and these the CT scan being ordered or being performed. How do you think we should handle inaction or delayed action? So for example, a lab test could have been ordered on day 1, but wasn't, but it was actually ordered on day 2. for example. That doesn't seem to be reflected on this clinical timeline. And I think a follow-up to Dr. Yao would be if we reason about these large clinical behavioral models that can change so many things, so many clinical actions over time, what's a realistic pathway to like evaluate such models? Thank you.
Yeah, no, I think it's a very important question. I think by bringing time to the core of this, it actually lets you get exactly at that question. And I think it is the right question. So one of the things that you can ask is not just, was that lab test ordered at some place on the pathway, but at what point in time, in response to what information, was it ordered? And then I think back to an earlier question in terms of optimizing for different outcomes. I mean, you can think about optimizing outcomes in terms of how long did it take you to get to the diagnosis, or how much did it cost you to get to the diagnosis, or how much extra stuff did you order, or what was the delay? So I think those are the sorts of questions that embedding time at the core exactly let you go after. So, and very interesting interfaces of this with causal reinforcement learning, which I'm happy to talk to you about later, which would be great.
Yeah, for the other part, I think I still like some sort of randomization at the real time, because if you really think this is uncertainty, this is a question how we should proceed, there must be some options. Often the question is clinical trial evidence is not strong, it's small, and it might not be suited for this patient. So if there is some sort of electronic nudge at some point, we can use that nudge as an IV or some sort of get to the causal inference. Even at each step, there are a few nudges. Even change the sequence of display can nudge a provider select one or the other, so we can more reliably get to the causal inference question.
Totally agree.
Okay, I want to thank you all for your great questions, and let's thank the speakers again.
Thank you.